Today I am here to speak about evaluation and management of overactive bladder syndrome. Before we actually move on to talking about overactive bladder syndrome, I think just a background understanding of how the normal bladder functions in women and why certain incontinence problems would cause more problem to women than to men is useful to start with as a background. In women, the urinary bladder simply functions as a reservoir which will hold urine until it is socially convenient to void. Particularly for women, it's impossible to void in public. So you can sneeze, you can cough, you can laugh in public, but voiding in public is not. Voiding is an extremely private function. To a certain extent, it may be different for men, and that's celebrated even in historic statues. As you can see, you would never find a statue of a woman urinating in public. So basically, this acts as a reservoir. And the anatomical background to this comes from the fact that you have the detrusor muscle, which is the smooth muscle, the internal sphincter, which is present at the bladder neck, and the external sphincter plus the pelvic floor muscles. And these are the anatomical structures which aid in maintaining continence. And what happens to the physiology part of it? The bladder goes through a filling and storage phase, and during the storage phase, usually there's constant filling except when you have bladder irritants like cola drinks or coffee, then filling occurs at a more rapid phase. And the detrusor muscle, which is a smooth muscle, usually accommodates and relaxes to allow this filling to occur. And then starts the first sensation to void. That happens approximately when the bladder is half full, about 150 to 200 ml. When there is a sensory stretch, and then there is a slight perception of the need to void. And at this stage, the woman postpones her desire to void. That is, the signals go to the sacral micturition center. Once they reach the sacral micturition center, this then is transmitted to the central part, that is the pons and cerebrum. And if it is not socially convenient to void at that point of time, then the bladder continues to fill because there's inhibition from the sacral center. But the brain is warned at this point, and you're told that there is a need to void, and after some time this is going to become imperative. So you start looking for a socially convenient time and place. If you're in a marriage, you'll start looking to see whether there are clean toilets, or if you're in any other public place, you'll start looking to see whether there are clean toilets, and if they are not there, you'll start planning to go home. So this is what this does. And then at a certain critical phase, the urge becomes very strong. You cannot defer the desire to void anymore, and the signals then go from the bladder to the brain, returns via the somatic tract, and a decision is made to void. You make a voluntary decision at this point to void, and the woman sits over the toilet. The external sphincter and the internal sphincter relax, and the detrusor contracts long and hard and empties the bladder. So this, in summary, there is a lot of autonomic and neuronal control which occurs in maintaining this filling and emptying phase. If you can see, during the storage phase, we know that the detrusor muscle is relaxed. The internal sphincter is tonically contracted. The external sphincter is also contracted and closed, and that's how continence is maintained. In the storage phase, the parasympathetic nerves are completely inactive, and the sympathetic nerves are active and maintain the storage. When emptying occurs, the detrusor muscle is contracted, the internal sphincter opens up and relaxes, the external sphincter opens up and relaxes and allows urine to be passed. The parasympathetic nerves become extremely active, and the sympathetic nerves are inactive. And this is important because this forms the basis of the pharmacotherapy in cases of overactive bladder syndrome, and the normal number of voids per 24 hours is accepted at 5 to 7. The average time interval between voids is about 2 to 5 hours. In the young, you can expect a goal of 3 to 4 hours. In elderly, 2 to 3 hours. And the total number of nighttime voids in the young should not exceed about 1 per night. That is, you shouldn't wake up more than once in the night if you're under 60, and not more than twice in the night if you're 65. Any disturbance in this pattern leads to overactive bladder syndrome. Basically, overactive bladder syndrome is defined as presence of frequency, presence of urgency with or without incontinence, presence of nocturia, and essentially this should be in the absence of any other identifiable pathological or metabolic process affecting the lower urinary tract. So this is what is overactive bladder syndrome. Frequency is, going to the toilet more than 8 times in a 24-hour period. Urgency is a strong and sudden desire to urinate, and incontinence is your inability to hold urine and wetting yourself by the time you reach the toilet. Nocturia is increased total number of nighttime voids. So presence of these conditions is defined as overactive bladder syndrome, but essentially you must remember that there should be no other identifiable pathological or metabolic process, and these are diseases which can affect the lower urinary tract like urethritis, cystitis, diabetes mellitus, diabetes insipidus. So if you want to diagnose pure overactive bladder syndrome, it is a diagnosis of exclusion. So you evaluate and rule out all the pathological conditions that can contribute to the symptoms of frequency, urgency and nocturia, and when you come with a clean chit, you will call it an overactive bladder syndrome. And how do you then manage this condition? One of the first steps in managing an overactive bladder syndrome is to initiate conservative management. That is, you first start with behavioral retraining or bladder drill, lifestyle modifications and fluid management. So when you talk of bladder retraining, we must remember that the bladder is actually a trained organ. Children are taught continence. They are taught to identify the desire to pass urine and to express that desire, and then they are taken to a toilet, and this is essentially what forms toilet training in young children. So you retrain the bladder by increasing the voiding intervals. You encourage the woman to try and train herself to increase voiding intervals. And this actually, when she starts doing this, because it is completely under her voluntary cortical control, you must remember in the physiology of micturition, I said that the signals go to the pons and cerebrum. So if the woman, makes an active effort to postpone voiding, it is possible. And this is associated with a success rate of up to 60%. And this requires a lot of patience both from the woman and the physician treating her, and it should be persisted with. She should also be encouraged to keep a bladder diary. A bladder diary is essentially, how often she is voiding, what she is drinking, and this can be used not only to aid your diagnosis, but it gives her a good visual feedback to evaluate outcome. If she continues to fill the bladder diary while she is, retraining her bladder, it gives her a lot of feedback about what is actually happening, and she should be encouraged to do that. Fluid management is extremely important to bladder drill, because there's no point in you having a woman who's drinking lots of fluids, because this is the fad of the day now. You find that people drink to lose weight, people drink to have great skins, especially women, and they drink at specific times of the day. I mean, I've encountered women who have 3 liters of water as soon as they wake up. I mean, this is really going to kill the bladder, isn't it? By 8 o'clock in the morning, she's running to the toilet very frequently, and that's not surprising. So you need to make sure that she's taking adequate intake, and you need to eliminate certain specific triggers like fizzy drinks and alcohol and caffeine. And lifestyle modifications again are very important, which consists of weight reduction, smoking cessation, control of constipation, and dietary factors should be considered, and this actually the woman can identify it herself. It's very useful to tell her while maintaining a bladder diary, also to identify certain specific triggers which can precipitate these symptoms in her, and you'll be surprised with the kind of things that women can come up with and how useful it is for them to aid this. I can't see a timer anywhere, and that's bothering me a lot. Okay, right, thank you. Okay. So having done this, then comes the next step, which is pharmacotherapy. So the basis of pharmacotherapy is the use of anticholinergic drugs, and these drugs essentially act by modifying autonomic control, which we have spoken about. We know that the sympathetic nervous system acts during the storage phase and keeps the bladder full, and the parasympathetic nervous system facilitates the process of micturition. So just for you to remember, the sympathetic facilitates storage. Parasympathetic allows the woman to pee. S for S and P for P. I mean, it was very hard for me when I just started, so I used to find this very easy to remember. So the anticholinergics basically target the parasympathetic nervous system. They block release of acetylcholine and hence permit storage of urine. But it comes with other problems also. The pharmacotherapy of overactive bladder syndrome is based on inhibiting the action of acetylcholine. Acetylcholine basically via the parasympathetic nervous system stimulates detrusor contraction, and this happens through the muscarinic receptors. And there are 5 types of muscarinic receptors, of which M2 and M3 account for the maximum number of receptors present in the bladder. You have receptors present elsewhere, and this is important to remember because if there is no uroselectivity, you can have a lot of side effects with anticholinergics. So the oxybutynin is the most widely used anticholinergic drug. Just going back to the previous slide, I would like to emphasize that the mechanism of action of anticholinergics is the same pathway that they use to, manifest their adverse reactions which come through. So oxybutynin is the most widely used anticholinergic drug, and the dosing regimen requires titration of the drug against symptom relief and adverse effects. So it's important because when you start anticholinergics, it's important to start them in the lowest possible doses, evaluate the response, and you escalate the dose only when it is required, because if you start at the highest possible dose, the possibility of discontinuation of therapy is very high because it comes with higher side effects. So start with the lowest possible dose, and oxybutynin is actually not uroselective. It can act on M1, M2, M3, all these receptors, and a lot of side effects have been reported with oxybutynin in the form of dry mouth, constipation, blurred vision, headaches, restlessness, nausea, vomiting, and dry skin and hot flushes. So what are the alternatives that we have if a woman reports these side effects with oxybutynin? We have some newer anticholinergics which have evolved, that is tolterodine, darphenazine and sulfanicine, which are available right now in India. And some of them are uroselective and some of them are not uroselective, but these have a better side effect profile at this point in quotes. And if you can, but the other aspect that I would like you to look at is the cost effectiveness. Oxybutynin is non-selective. It acts on all muscarinic receptors. You need to give it 2 or 3 times a day, whereas darphenazine and sulfanicine are selective and it's once daily dosing. But if you look at cost effectiveness, it's proportionately much higher. And at this point, I'm not saying that you should limit a patient's ability to have effective therapy because of the cost of the medication. That's something that can be worked around, but it's important to look at it rationally and see whether it's worthwhile actually just straight away starting with the better side effect profile medications. And there is no evidence to say this. Are they really better? We really don't know still. They all share similar efficacy. They differ in their chemical structures and the balance of anticholinergic adverse effects, and most of the trials that have been conducted on the newer anticholinergic agents have been by pharmaceutical companies on very highly selected patient cohorts, and there is a real need for impartial large multicentric randomized control trials in a more clinically realistic setting. So until then, it is still useful to start with oxybutynin, and the important thing with oxybutynin is that you need to start it at the lowest possible doses and titrate it against the patient's symptoms, and you will notice that when you do that, the side effect profile automatically comes down. It's very dose related. So start with that and then move on to the others. Then the other way of circumventing the side effect profile is by an alternative route of instillation, and intravesical oxybutynin therapy has been found to be very useful. And but it requires high level of motivation on the part of the patient, because she needs to do clean intermittent self-catheterization at least 2 times a day to instill the oxybutynin. Now coming to nocturia, the other symptom, the pharmacotherapy for that, imipramine is an anticholinergic and tricyclic antidepressant, works very well for nocturia, and so does desmopressin. What about estrogens? irritative urinary symptoms like urgency, urge incontinence, and frequency can be improved by estrogens in postmenopausal women. And it is better that these are delivered locally in the form of creams or vaginal tablets. And because we know that estrogen receptors are found in the epithelial tissues of bladder, trigone and urethra and levator ani muscles. And definitely local estrogens improve irritative bladder syndrome. And the newer therapy now is the neurotoxin therapy, which is the botulinum toxin A injection. However, it is indicated in women who have had symptoms of overactive bladder syndrome for at least 6 months duration, and they've failed with all anticholinergic regimens, or they have severe side effects, or there's an absolute contraindication to giving these medications. But there is really, at this point of time, I have to issue a word of caution. There is complete lack of evidence and consensus on what dose of oxybutynin should be given, at what sites should it be injected intravesically, whether or not to spare the trigone, or whether we need to give other adjuvant agents to improve result. It also comes with a postoperative voiding difficulty rate which varies from 4 to 45%, which is extraordinarily high. Voiding difficulty is an extremely distressing symptom, because if this happens, the woman has to learn to self-catheterize, or she has to be on continuous catheterization. And with intravesical botulinum, the level of postoperative voiding dysfunction is extremely high, and so we have to be extremely cautious when we give this, because we don't have any standardized regime still. Some newer forms of therapy have come in, and they are still under evaluation. These are in the form of nerve stimulation. Posterior tibial nerve stimulation actually is presenting a very promising modality of treatment, because it seems extremely non-invasive and very comfortable. Sacral nerve stimulation is done only in selected centers for very, very poor cases. Again, surgical interventions are only for very refractory overactive bladder syndrome, where you take the woman through complete counseling, and you can either go for a bladder augmentation or an ileal conduit. These come with their own problems, specific complications. It particularly with bladder augmentation can be in the form of bladder rupture or intestinal obstruction. So since they come with a very high adverse effect profile, you need a complete discussion with the woman, because finally it is her quality of life which has to be improved. When you're talking of overactive bladder syndrome, you've actually ruled out pathology. So these symptoms are simply, you have to make them proportionate to the quality of her life and to what extent she wants to go to get these relieved. And so this is an algorithm about how you should manage urinary frequency, urgency, urge incontinence and nocturia. Basically put them through an initial evaluation to rule out pathology. Once you have ruled out pathology, put her through conservative measures. Pharmacotherapy is basically the strong foundation of therapy for all overactive bladder syndrome, and I think that should be tried. Try it in a graded manner. Start with the medication which is the cheapest, most effective, give it in doses which cause least side effect profile and most effective symptom relief, and then move on to the newer agents if required. And then the other therapy is reserved only for extremely refractory cases. So overactive bladder syndrome, it's actually a very prevalent symptom complex. I'm sure you see it very frequently in your own clinics. Lifestyle and behavioral retraining should be addressed initially in the treatment plan. And there is really robust and convincing evidence that anticholinergic agents are effective drug treatments. All other modalities of treatment have very little evidence, and they have very debilitating